We dive into the subject explaining some tricks. I want to start off by thanking the American Association of Oral Maxillofacial Surgeons and Dr. Luis Vega for this honor and invitation. I'm going to focus and immediately dive into the subject explaining some tricks, some tips, some methods to develop a smooth and predictable workflow if you are dealing with patients with clear aligners. So clear aligner therapy has taken the orthodontic world by storm. It's really turned it upside down. Two camps. The one camp really embraced it and thinks it's a messiah of orthodontics, and then there's another camp that's really skeptical, particularly because the finishing isn't so good. And that's a bit of my spoiler alert. I don't here be a proponent and expecting to say to you that this is a better option. By no means. I'm using this as a platform because you will be seeing these patients. This is an inevitability. I think the expression is, if you can't beat them, join them. Currently, about 20 to 25% of the patients that I see for new consultations are in clear aligners. I think partly because the orthodontists might know that I do it, but it is definitely growing. So patients are what's driving this. They love it, and that's the reason why you see it. The company Invisalign is also doing very well. They are loving it as well. Align Technologies started almost 20 years ago now. It is the largest supplier of clear aligners, over 8 million cases numbered up to 2019. Just in 2018, almost 1 million cases. They have close to $1.5 billion of sales. But the orthodontists sometimes are not too happy. There are things like this Smile Direct Club, where patients go and a hygienist will scan, and here's one close by in Richmond, Virginia, and then they can send you 2 weeks later a whole series of aligners. So for orthodontists, it's been, as I said, a double-edged sword. It is bringing in new patients that normally wouldn't have done orthodontic therapy because they didn't want the full fixed braces. But on the flip side, it was Align Technologies that used the orthodontic brains to help set up the algorithms to make this process simple. And then after about 10 years, they opened it up to general practitioners, much to the dismay of the orthodontist. So now general practitioners have exploded with the use of clear aligner therapies. So they may, in a sense, be taking patients away. But it's no different than I find implant therapy in our specialty. We no longer do the easy cases, right? The easy cases are done by general practitioners, periodontists. We tend to see the complex cases. And the same thing seems to be flowing out with orthodontic therapy. You hope that the general practitioner might be doing the easier cases, and if it gets a little trickier. So I started about 15 years ago with orthognathic surgery and clear aligners because I had to. It came up, and we tried with trial and error on how to best do it. And I'll talk to you about these early days. There are surgical challenges and orthodontic limitations. I always tell the residents and colleagues as they're building orthognathic practices that if you want a successful practice, you have to think like an orthodontist. You have to worry about an orthodontist. What time am I going to wear in the morning? How am I going to do this case? Where's the anchorage coming from? You have to understand their vernacular, particularly in regards to orthognathic surgery. I'm going to look at some protocols for yourselves, a surgeon, some steps, and also protocols that to share with orthodontists. I've shared these lectures with some steps with orthodontists in your publications in the Journal of Clinical Ortho on these little steps, but it's good to share with you to show them what's best to do. Now, I enjoy doing orthognathic surgery with clear aligners, and for some cases, like segmental cases, it's my preference. It does work very well, but it's taken a little bit of a toll. I've been burnt a couple of times, and that's why I'm here to show you some tricks. So clear aligners, there are many types worldwide. There's about 40. North America has about 30 that are registered. The number one is Invisalign. It's about 90% of market share. Clear Correct, Sure Smile, Incognito, they're all the next ones to come up. There's also the ability for orthodontists to do this themselves. And I have some orthodontic colleagues and program directors in the U.S. that have their own labs where they have the ability for rapid prototyping and can make the splints themselves. So you don't have to use these companies with 3D printing. It's all done by yourself. And the concept isn't new. Kessling in 45 was the first one to come up with it and basically took models. He cut each individual tooth, moved the teeth, and he made a rubber positioner. The patient will wear the rubber positioner for 2 weeks. Take another impression, change the teeth again, make a new positioner. This was laborious. In the late 90s, two Stanford engineers, young kids just out of ortho, said there's got to be an easier way. And they came up with the rapid prototyping from Kessling's idea. The primary advantage of clear aligners over traditional is aesthetics, removability, and comfort, but it's not outcome. Not outcome. The peer review is not great. There are some studies that are try to bring some things together. I'll share those with you. But most of the studies are case-based reports, small sample sizes. The methodology isn't great. They're not blinding. It's a common tragedy with most of our clinical research. It's not that easy, so it's not that I'm blaming anybody. It's not easy to study. This is a good study looking at just models post-op. So this group did a multi-center randomized trial looking at models. And the models were of patients that either had clear aligners or full fixed. And the reviewers didn't know. They were blinded. These were all the same, class 1 cases, extraction. And they looked at using an orthodontic grading scale. And this grading scale is used by the American Board of Orthodontists to evaluate what the final outcome is. So it's a very stringent, it's a high, it's not easy to get 130 out of 30. It's a tough scale. But this study showed, in a nutshell, there really wasn't a difference between the alignment, marginal ridges, occlusal relations, overjet, position, root angulation. It wasn't all that different in these cases. So here's the OGS written here. Invisalign on the left, you can see 2/3 had a pass mark and 1/3 had a fail mark. And you say, oh, wow, that's an awful high failure rate. But this also lends to how rigid the OGS scale is. So look at the full fix, a quarter failed. So it's not that bad. Focusing in on the certain elements. So clear aligners, definitely longer. There's no issue. Even patients know that, and they're willing to accept it because they're not wearing any metal. Overall, the final, statistically significant. The buccolingual inclination isn't very good. I'm going to show you a case where the canine is completely out of place and ortho was unable to move it. The occlusal contacts are not as good, and I'll show you some cases of my outcomes. But overall, if you look at this scale of the failure rate, it's not that bad either. What I like to tell my residents, also patients, is with full fixed orthodontics, we can get you like a 9.7 out of 10. We can get almost perfect. It's not always perfect. With clear aligners, you get a 9.1 out of 10. So it's still not that bad, but it's not just as good, right? So it depends on the type of patient that you have. So here another study, it's a systematic review looking at the clinical effectiveness of Invisalign, and their conclusions are pretty standard and what I'll be saying the whole time. Invisalign clear aligners are a viable alternative to orthodontic therapy, but for mild to moderate malocclusions, non-growing patients that are non-extraction. So some of the points, limited efficacy is seen in arch expansion, extraction of spaces, corrections of occlusal contacts, and large AEP vertical changes. So just in summary of some of these findings, it is very difficult to do orthodontic therapy with clear aligners because there's a challenge in maximizing anchorage, and then throw in a patient that's non-compliant. It's hard to treat severe crowding. I put this down, manage misshaped round peg teeth. I put an asterisk because I'll talk about this later because I actually have cases where it's beneficial. But you can imagine a very round, small canine has nothing to grab onto. That's why they tend to use the attachments. It's difficult to mesialize teeth, and it's difficult to close extraction spaces. Uprighting teeth, extruding teeth, and as I said, fine finishing. Some of the challenges from a surgical orthodontic perspective is that it's a new industry. And when we started off with the virtual digital planning or their ClinCheck, the initial Invisalign was all meant for compensatory treatment. So when it started off 20 years ago, it was to compensate the occlusion, normal orthodontic, non-surgical approach. So the ClinCheck, that virtual planning, was very difficult to perform. There was challenges intra and post-operative because you didn't have braces, fine finishing. I remember back when I first, 17, 18 years ago with clear aligners, I won't do this because I need braces. I need braces to grab onto something, but no longer the case. So what is ClinCheck? ClinCheck basically is our virtual surgical planner. And you can see here with each jump is a new aligner. And there's the post-jump that's predicted after surgery. So ClinCheck is what the orthodontist does as a 3D virtual planning, but they don't have the control like we do when we do orthognathic planning. The technician presents to them the case. They approve or disapprove or make notes about what they want changed. It's resubmitted, and another one is done, so they go back and forth. So it is a little challenging for them. I just wanted to show you what the attachments are, because you'll hear me say that word. And I'll give you an example of the problem with ClinCheck, or the initial problems with ClinCheck. So here's a case. Class 3 had previous orthodontic therapy with full fix. It was a surgical case. The patient didn't want surgery. Everything was demanded. 3 years later, shows back up again to the orthodontist, says, you know what, let's do the surgery. But I'm only going to do it with Invisalign. So the orthodontist straps them up with Invisalign, and we do the ClinCheck together because this is one of the first cases. And the case here shows the limitation of the case. So here you have an example of the engineer doing the changes after there was a correction. So the initial phase was trying to change this with compensatory treatment, and the compensations just made it worse. So here's an example. So I don't know if I point you, but you can see between the lateral and canine, there's a large space. So the technician, in preparing the surgical case, has made it worse. He's trying to correct he or she's trying to correct the occlusion, trying to correct the midline. And as you know, for surgical cases, that's not what's needed to be done. So finally, the orthodontist gets a hold of another orthodontist at Align Technologies to review the case. And then they finally set this up with the well. On the left panel, you see the pre-surgical setup, and on the right panel would be the post-jump, post-surgical changes. So it was a bit of a struggle to get them to learn about what compensations are required. So I've made some notes, and this relates to your orthodontic preparation. It's for the orthodontist. And there's a little scan here of the PDF that you can scan, or if you simply want to take a screenshot. But this is the list. It's a little bit exhaustive. On the left-hand side, the green part is already in Invisalign ClinCheck. That's the checklist that the orthodontists have to fill in. So it talks about the arches to treat, the teeth to treat, the movements, obviously both. It's funny, arches to treat sometimes, and you'll see some cases where they're only doing the Invisalign in the maxilla with full fix on the mandible. I think less and less are the practitioners doing that, because that's a little bit of a disaster, because they can't plan on how the wired arch wire is going to behave with the teeth compared to the plastic. So I'll just give you an example of how we run through or some of the changes to emphasize. On the purple, on the right side, this is what I added with the help of my orthodontic referral base on pointers if it's a surgical case in some comments. For example, if we have a case just non-surgical with Invisalign and we need to change the AP relationship, a non-surgical case, you just want to improve it. You want to compensate the occlusion. If it's a surgical case, you want the opposite, right? You want to worsen it or at least maintain it. Here's another example would be for midline correction. If this is a non-surgical case, the midline is corrected with IPR, even extraction sometime, and the teeth are tried to be pulled over. If it's a surgical case, that's the last thing you want to do, because if it's a surgical midline discrepancy, it's the bone that you have to move. So you have to maintain that midline, and you always have to tell the orthodontist, don't worry about the midline, I'll fix it. So here's an example of a very well executed case. This is a recent case. The orthodontist sends me these ClinChecks so I can see everything that's happening. And you can see in all the dimensions of this video, the sequencing video. I'm sorry, let me try that again. But you can see from the top one here, particularly what's happening. So this is being properly decompensated. As the occlusion is straightened out, you see a better overjet. So very good compensations. You're not seeing an attempt at the transverse discrepancy to be corrected. And then very soon you'll see the post jump, and there's the jump. So the case up to number 34, we'll do this again. So this is 35 trays, and that jump from 34 to 35 is the time of surgery. So this is a well-prepared ClinCheck for the orthodontist, providing the patient with the right number of trays. So here again is the PDF and the checklist. If you're, and it's very helpful for the first few cases, particularly if you're going to work with the orthodontist, particularly about the issue of decompensation. So enough ortho. Let's talk about surgery. Right? That's what we're here for. So I'm going to start off on the challenges that we had. Initially, we couldn't really get our mechanics in. As I said, I wanted braces to hold on to it, but it's not always obvious. Some of the prescriptions are difficult. The finishing is not perfect. Some cases are difficult to treat, and make sure the first few cases, don't do extraction cases, because the tipping isn't there, the contacts won't be there, you won't be able to set up your occlusion ideally. Class 2 very deep bite cases aren't good, they're very hard to do, but some cases are easier. I love doing orthognathic surgery that's segmental efforts with clear aligner splints. Things fit in better, it's neater, it's cleaner. So there are some benefits. Surgery first with clear aligners in class 3 cases work very well. So initially it was very slow. We were reluctant to jump into this because the preoperative orthodontic prep was difficult regarding compensations, decompensations. You really do need digital planning, intraoral scanners. By now, if you do many cases, you should have a scanner, you should have a CBCT, or at least the accessibility for that, and the full digital planning. And I've given previous lectures here at Amos about the benefits of that. Now, the evidence for clear aligners and orthognathic surgery is very limited. It's just case reports, and I'm guilty of that as well, and little expert opinions. But I think with time, as we're developing, there's been some more reviews coming out recently to help strengthen that. So, and one of the limitations was the perception that, you couldn't localize, mobilize, position fixate the dental alveolar segment. It was just too hard to do. Was the concept. So how do you do intraoperative fixation? We would, you can use Eric arch bars, but there's no way that these patients, sorry, the slides aren't syncing properly, but otherwise you can use maxillomandibular fixation devices. The problem with these MMF screws are they're bulky. You can't leave them there for a long time because they'll cut into the gingiva. There'll be issues with those. So what I do instead is I put these little temporary anchorage devices. Really what this is one of my 1.85 millimeter rigid fixation screws of the maxilla. It's much cheaper. It's easier to place. You only need them for a couple of months anyhow, and use them for intraop. Another option is you can use the screwed retaining devices, but this is even worse than full fixed. Very early, this is like a 15-year-old case, we would put these little brackets, because if we had brackets on the teeth or buttons and you wire them up, they all pop off, right? So one of my orthodontist colleagues said, I'm going to put this right up to the CEJ. And what happens is the shearing force is diminished, so the brackets wouldn't pop off. So a little ingenious ortho maneuver. So these worked well for a while, and also we can cut out the trays. Align Technologies has these little buttons that you can attach for wiring right beforehand. The only thing that these things are good for are for fishing expeditions in your sagittal split site, because they all pop off and you can't see them. And they're little pieces of glass, right? Then another option is to put the patients back into full fix before surgery, do the surgery, keep them in for a couple of months and send them out. But I think that's not necessary. And then finally, the use of clear splints. Everybody's coming up with some ideas on how to best do it. The planning companies have these splints that work quite nicely, and I'll show you a little bit about them. So here's an example of the clear orthognathic splint in place. Here's the this is the sag split has been completed. You can see on the left panel some MMF screws to hold it temporarily. And I want you to see that you can see, because the splint is clear, you can see the teeth engaged fully. So you know that it's fully seated. And if it's not fully seated, you do see a gap. So you can either push the wire or hold it together. The patient then had a maxilla, and this is after the second splint is removed. And I mean, this is a dream in any case, and this is probably why I took a picture of it and sharing it, because, you know, if we got this all the time, this would be a fantastic job. But this is an example of how you can set the occlusion quite nicely. So here's a case very early on. I showed you the picture, and I would start with simple, easy cases. So class 3 mandibular prog with a sag setback. And so these are the close-up of the little brackets. There's a ceph. 2 weeks post-op, nice and clean. There's just maybe a little bit of plaque burden, some elastic, so I like to use these afterwards. And the patient has his passive aligners in place. So to clear the Invisalign passive aligner, so it's not doing any movement, it's just holding everything together. And the orthodontist, we just cut these out so it fits nice and comfortable. And 1 year, so one of the issues is looking, I want you to look carefully on some of the results. There's a little bit of an open bite, and that ends up being maintained, and it's very hard. So when you're post-op, he looks good, he's happy, the midline, the occlusion is good. On an OGS scale, out of 30, he's probably a 25, but it's still a pass. You can see there the open bite. So the finishing just isn't there. And this is what the post-op ceph looks like. Then I got a little bit more, not aggressive, but then started doing double jaw surgeries with the same sort of splinting method. So here's a case. She's VME class 2, with forward impaction sag advancement. Here she is 3 weeks post-op, and I like to show this picture because of the swelling and how clean it is. It is really very clean. It works out nicely. And then here she is 2 years post-op. So we're looking at the two results. You want to compare the occlusion, right? And the occlusion 2 years post-op isn't so bad. It looks pretty good. There's a little bit of gaining of overjet. OGS scale, probably also a 25, which is a pass. And here's some images of what she would look like during the time. You see the brackets that we used to hold things in place. I also would at one point make laboratory aligners. I would make these myself. So this would be, I'm talking 2005, where I would go to, I would go to my lab and I would fabricate an Essex retainer to help clamp all the teeth together. This is very quick, easy, it's cheap, costs $1. You don't have to remove any of the attachments. The same thing, you still use the same tabs. Forget about buttons and arch bars, and it positions the teeth into occlusion and gives you a good stability. You do need an Essex retainer. So in my lab, I had an Essex former, used denture acrylic, put the teeth on. This is for single jaws. So put the teeth on a Galetti, set the occlusion as I want, fabricate maxillary and mandibular Essex retainers. Then once I had the ideal occlusion on the Galetti, I put my retainers on there. I wet them. I make a little ball and powder of acrylic, and I place the acrylic on there and glue it together, and this is nice solid piece. We go to the operating room, so this is what it would look like, and it does engage everything quite nicely. So this would slap maxilla and mandible together and completely rigid using supplemental tabs if it's loose at all. And an image of this post-op. So 2 weeks post-op, these little buttons are placed by the ortho, and this control. This is actually the patient's clear aligner, the passive aligner. This is not my splint, but at least it shows you what it looks like 2 weeks post-op. Again, just notice how clean it is. I also tried doing some splints this way, where I set up the ideal occlusion in stone. Again, this is a very old image, but I would take an acrylic ball and I'd mold it to all the teeth and use that to engage the teeth. The problem with this is it's too tight. And, sometimes the models, the teeth would break off. And then when I'm there intraoperatively, and it was so difficult to take off, I was worried about breaking teeth. So the clear aligner ortho splint works well. But this was another option. This is sort of the development of the challenges that we had. And then slowly we evolved into clear aligners. I think these are clear aligner orthognathic splints. I cheekily call this a chaos splint, but I by no means claim that I've invented this. This has just been an evolution of other people that have thought of these things. We had a little publication last year just on some steps that are handy in fabricating these. But these clear aligner orthognathic splints, for myself at least, have been a game changer. They are intended just for patients who have no braces. So it's not just for orthognathic surgery. I also use these in patients for maxillomandibular advancements for sleep apnea, because it does grab the teeth very well. You can't have anything on the teeth. Any attachment on it will diminish its adaptability and the tightness, so to speak. So it's engaged to go in the undercut. So the difference, this chaos splint is specifically made to go underneath the undercuts. Normally, when you're getting your splints made by the digital planners, they will not go below. If you look very carefully, there's this fine line of the height of contour, and that's all they're going to work with. When you're doing the clear aligner orthognathic splint, you have to ask them to go below that height of contour so that they can engage the plastic so you get some more retention. So that's what's a little bit different with this splint. And they do several functions. They position, they're your splint, they're your positioning splint according to your virtual plan. They also provide for stable maxillomandibular fixation. In some cases, this is all you need. It just traps everything carefully. Most of the time, though, you do need some TAT supplementation, and it's excellent at controlling the torque of segmental cases. This is why I'm saying, see in the lab, for example, this is the patient CT scan, and these are models, it's not a scan, but the models are what I want to see on the planning, because the digital planner has to go all the way up to the crown, full crown, and also engage into the buccal. So if you look carefully again at one of your cases, you see a very fine line, because the plastic that they create will not go past that line. So you specifically have to ask for that. So here's an example, and I also like showing this to remind everyone and try to convert those who are still shy with the digital planning that you can't do this on an articulator. You can't do this with stone and plaster and sticky wax and an articulator. The control of the segments with the digital planning, and in particular with these clear aligner splints, is remarkable. The segments slap into place with a nice feeling, when it snaps right in there, that's the sensation. And it makes it's faster. You don't have to deal with little wires, 28 gauge wires, and that extra 20 minutes to wire a splint in. This literally is a savior for time and also, I believe, outcome. It does help position that segment a lot better than our traditional method. Here's another case. So now we're starting to use our clear aligner splints. These are class 3, so small mandibular advancement, maxillary advancement, and mandibular setback, a tiny asymmetry correction. These are what the splints look like. So we fabricate the splints. Here's a pre-surge pen and ceph. And these are the intermediate and the final splint. Nice deep bite there. A complete occlusal coverage, but it's also thin. I want you to see here, this is poking through, so this is tooth-to-tooth contact. And you know that when you make your splints, the thinner they are, the better they are, so it eliminates the hinge change in centric relation. So the intermediate splint, the mandible is cut, this goes into place. Then we make the final splint, the maxilla is cut, and we put this into place, and that's our image. And this is the immediate post-op pan and ceph. So I just had to use 2 TADs on top and bottom just to help a little bit more belts and suspenders, and then also for some elastic wear afterwards. And this is 2 weeks post-op. Look how clean this is. It's clean and very little swelling. And so this patient is wearing it. Now the orthodontist is going to close and do some finishing ortho. And this is what the patient looks like 1.5 years post-op. And so this is not a bad result. The finishing still isn't as perfect as you'd like it to be, but here's post-op pan and ceph. Here's your pre-op, post-op. So your canine position isn't ideal. Again, they have a challenge in uprighting these canines and root torque inside, and also you see some contacts not perfect, but it's not so bad. Here's another case. Initially, we would also see a lot of cases where the orthodontist wasn't all that comfortable, so they put full fixed on the mandible because the patient can't see it, and then clear liner on the maxilla. This is, I think they're doing it less and less because it's really a disaster, because you have one technology mechanics for the maxilla and then wires for the bottom. Neither of the talk to each other in a sense, so the planning is a little bit off. And these cases haven't turned out really all that great, but just to give you an example of why I like using it. So this is one of my first segmental cases, and the splint just fit the maxillary teeth. The segmented case would snap into place. Just a little quick note about mandible first surgery. I prefer doing mandible first for almost all cases. I do think it's quicker. The issue of not dependent on centric relations is not entirely true. Not as much, but that's another lecture. The fixation is stronger than the maxilla, so you can do the mandible first, put in the big screws, go to the maxilla, move things around, and you're not going to get it wiggly. The only time I will do maxilla first still is if I have large impactions. So regardless of class, sorry. So VNE, and I'm moving it up 5, 6, 7, 8 millimeters, then I'll probably tend to do maxilla first, because it's very hard to, it's easier to position that impacted maxilla when you're doing maxilla first. That's small nuance. I digress. So back to this, here's the final splint. So again, you can see the holes here. That's what I like to see this. I don't want a big thickness between the two segments. I want tooth-to-tooth contact. I almost want them touching, so I know that will be maintained. So here's the segmentalization. Actually, the video was of this kid here before. Here, intra-op, what things would look like. So I have belts and suspenders. I've got my splint holding the maxillary dental-alveolus in place. It's indenting in the mandible, so there's full fixed in the mandible. My TAD is holding the whole complex together, and then I use this to slowly trim everything off. The next slide just shows it being removed. So as we try to take these cases off, I'm sorry, this is completely out of sequence. But here you go. Here you can see it takes quite a bit of effort to take this down at the time of. I apologize. So this is what it looks like 5 days post-op. 2 weeks post-op. This is the patient. Very little swelling. Nice and clean. It looks good. These patients are happy, and their post-op results are good. His post-op result was killing me because this canine didn't move, and a bit of a lunch bag let down. But nonetheless, the change of aesthetic also was very good. Now, how do we maintain if we've expanded the maxilla? So we use now the initial splint, final splint, and then this small palatal splint. This palatal splint is inserted after the case has been fixated. So here's the image of this palatal splint. So this maxilla has been segmentalized into 3 dental-alveolar components. It's been expanded. You can see on the upper right panel, the amount of expansion. So there's one splint to position the maxilla. It's fixated. You then remove that splint, your chaos splint, and then you insert a palatal retention splint. And this retention splint fits very nicely in stylotomy, and it is an excellent method of retention. I even use it now for my full fixed cases, so that instead of having a splint in place, I'll use this, because it holds things quite nicely. Here's an image of what they look like. So here's a complete case. Intermediate splint, final splint, and then the palatal splint that goes on. You can see the width increase from intermediate to final. And just some points on this. So we use this. You first apply your chaos splint, put a patient in temporary MMF, place your fixation maxilla, remove the fixation, and then you place this in place. This is wired. We use 4 little wires. We use 5, 6. I would put 2. I put 4 little wires. Sometimes in the segmented area here, I'll do a wire spanning the 2 teeth just to hold it together. Or in some cases, I'll even put a little blob of composite resin over top to hold it together. One of the things that one of my residents called it helicoptering. So the first few times we put the palatal splint in place, and then we tried to pass these wires, and oh my goodness, talk about exhausting, because you never get it right. So what I do now is a little trick. I don't put the splint in. I hold the splint. I'll pass my 4 wires inside the holes. And so the splint now has 4 wires, or 8, sticking up. Then we helicopter it in. As we bring it to the pallet, we'll start passing through our little 28 gauge wires, and then slowly tighten it, and then the splint goes into place. A lot easier. So don't put the splint in and then try to fish it, especially with the 28 gauge wires, you get nowhere. So helicoptering is I like that term. Here's another case just showing the full maxillary impaction advancement, mandibular advancement, intermediate splint, final sprint, pre-op, CEF, 1 year post-op, CEF, some of the changes that were induced. And here's a nice aesthetic result and also very good occlusal result. That's what you have to look at. We have to look at the occlusion. The occlusion is key. And this one overall on the OGS scale will be pretty good. So I just wanted to quickly talk about planning less surgery, splint creation. So with the digital planning companies, we've been able to manufacture splints right away. So this is done for single jaws. My dental assistant sends the companies the STL file with a specific request to fabricate the splint. I have specifics in the prescription. We don't have a planning session. It's very cheap. They have 1 week turnover. I've had it even less when I'm super sweet. And here, for example, is a case. Well, all we did was send the scanned occlusion. This is for a case like this. And then they, in 1 week, send me back a splint. See, nice and thin there. And the reason I do this and that it works is because the digital planning company, I work with the 2 main ones and just specific engineers for each case. They will, they know exactly what I want, and I trust them in setting the occlusion. They set thousands of occlusion per year, much more orthognathic cases than I do. So yes, I do trust them. So that's pointless. So finally, I'm just going to tidy up with the notes. So the tidbits, things that, first of all, what you need to tell your orthodontist. So you're going to engage in this practice, you need to know ortho. So one of them is how to communicate with them. And this is how it starts off. So dear ortho, step number 1, remove all the attachments 5 weeks before. Rescan the patient at 5 weeks. Make them 4 passive aligners. Remember, each one is for about 2 to 3 weeks. A couple for before and a couple after surgery. If you're really nice, please send me the STL file so I don't have to scan the patient. So I have a few orthodontists that will scan STL, they'll send it to Invisalign, and then they send it to me. And then I'll take that STL file and I'll send it to my 2 digital planners. So second point to ortho. At 4 weeks pre-op, the patient is going to come to my office for the digital workup. The patient should come with passive aligners and no attachments. Remove all the attachments. Point number 3, at my workup, I'm going to do pan-CEF photos, CT, CBCT, intraoral scan if I have to, centric relation record. I take the patient's centric relation record, and that's how they get their CBCT or CT taken. They have to be in that bite registration, consent form, prescriptions. I give my patients a bag full of stuff. Point Number 4, I will invite you. What happens is the digital planners will send me, when you have to do your things. I do my planning on 2 days, one with one company, one with the other. It's usually about 4:30, which at 4:30 is the worst time in an orthodontics world to see, to get away from patients, right? It's after school, but I guess nowadays it won't be all that bad. And we'll design the splints. So I get them involved. But rarely do they come on now, but some of your junior orthodontists or people that start working with you, they're interested in it, and they hop on. Most of the orthodontists are like, yeah, go ahead, do it. So the final notes to ortho, I want you to see the patient a week before, make sure the passive aligners are fine, and then I don't want you to see this patient until 6 weeks afterwards. At 6 weeks, I want you to do a new intraoral scan, create your post-jump finishing aligners. So in the Invisalign world, surgery is called jump. So the post-jump aligners could be fabricated afterwards. The reason being that some orthodontists might make these aligners before surgery, and that's not a good idea because it's hard to predict exactly where the finishing might be. So I always say do your post-jump aligners, scan them at 6 weeks afterwards. I'm very strict. I don't want ortho seeing patients until 6 weeks because I've had cases where I've done a big mandibular setback, I've overset them back, they're in a class 2 molar position, and I have class 3 vector elastics. I want to keep it there. We all know we've all been burnt with large setbacks, how they relapse forward. The patient comes back to me with class 2 elastics because the orthodontist was worried he was in a class 2 position. And so I just say, just let me deal with the elastics. I know about the relapse and retention. Don't touch the patients for 6 weeks. So this is a summary. Remove all the aligners. Remove all the attachments and make new aligners 5 weeks post-op. You have to make 4 passive aligners for fabrication before and after. Tell them when your workup is. Tell them you can set the occlusion. I always set the occlusion virtually. See the patient 1 week pre-op and then 6 weeks post-op. Okay? Then, notes to yourself. So, dear self, how do I do my setup? In my pre-surgical phase, I will set the pre-surgical setup 4 weeks behind, 4 weeks ahead, because that gives me plenty of time. Make sure that the patient comes with their passive aligners. And during the digital planning session, I really reinforce for my chaos splints that I have full cut. I tell the engineer, please show me everything. I need to see this because I want to see how the splint is made afterwards. So before surgery, so now intra-op. So steps 4, 5, and 6. Intra-op, right before I remove put in the throw pack, I try in the splints. And I try to see how retentive it is. If it's really, really retentive maxillomandible, then I'll just put 2 tads. If it's a little bit sloppy, especially in the mandible, then I'll put 4 tads. That's it. There's no really great science to it. And for my tads, I use the fixation screws. One of the tricks intraoperatively, sometimes if the lingual aspect is fairly long, the tongue's in the way. So I use a gently curved freer. I gently, on both sides, just gently keep the tongue out of the way, try to put the splint in. Sometimes it is a bit of a bugger to get those in, but with time, because it relays how good the retention is and the positioning of the alveolar segments are. And then post-op segmental cases, you should put a palatal retention splint in, and I leave that palatal retention in for 6 weeks. Right? So 6 weeks, I take it off. The patient goes from my office to the orthodontist. I've had one orthodontist prefabricate, based on our virtual plan, a TPA, so that because it was such a big expansion. And then they went to the office and had the TPA inserted. Put little composite blobs on there. For open bite cases, if I'm not expanding, I don't use the palatal splint because I like the tads in there and I get some vertical control, and I do that immediately afterwards to try to deepen the bite as much as I can. And then finally, post-op, got to learn how to put the tads on the elastics. As I said, ortho doesn't see back. Sometimes I'll rescan it for the orthodontist. That makes them very happy. Just a note about these tads or elastics that you can place. There is a small teardrop plier. I have this. It makes a little cut in the splint where you can add the elastic. The problem is that sometimes it's sharp, but you give the patient a bag of elastics, they just keep replacing it. The other option is this thermal plier where the orthodontist moves that over. And then here's an example afterwards. I just needed some elastic control, so I made a little clip in both of them. This must be about 3 months afterwards. Here's another case. I just made a little clip here. I mean, you can do this with a 702 burr, but it tends to be a little bit sharper. So Added benefits of clear aligners are digital modeling, and in particular, the use of, I just want to quickly show you, here's a case where the patient, I thought, would need a surgically assisted rapid palatal expansion, but the orthodontist shows me that with the planning, the teeth fit nicely. So as a diagnostic wax-up, instead of a diagnostic wax-up, we use this technology here. So I'll show you this case up at the top again, and you can see how it jumps into position, and there's not significant crossbite. So I was shown, oh, you really don't need to do a SARPI, maybe a segmental effort, or maybe just even orthodontic. The problem, though, is it isn't that great. Here's another case where the expansion was done, and you can see here the change, and this is the mandibular body being moved inwards. I'm like, I don't know if you can really do that. And indeed, a paper, J.P. Houle, was showing that the transverse prediction is not as good. So this is the end. Some tips: remove all the attachments, have your passive aligners, hold the segments with composite resin, use fixation screws instead of MMF screws. I like using the clear aligner. The Chaos splints, hopefully I've shown you, are quite nice. They work well. No post-jump aligners. You really want to be nice to your orthodontist. You can try to rescan the patient 4 to 6 weeks later and send them the STL file. They'll love you for that, especially because of the trismus that still be maintained at 6 weeks. I use the aligners to hold the elastics after you remove the TADs. So the initial observations, some disadvantages about the evidence, tooth movement limitations, open bites at the end. I showed you some cases. It is compliance dependent. But the advantages overall, definitely aesthetic, removable. Oral hygiene improves tremendously. Patient satisfaction. There is an issue. I do believe that there's less swelling. And Steinbacker's done a lot of work on this. It's a great little article. But the number of cases were small. And I think he and I, we agree there is less swelling. And he tried to show the edema, but really not statistically significant. Another recent study looking at surgery first that shows a positive aspect. The article is all right, but it does lend at least a tendency for improvement. So I'm just going to end you off with a current study that we're doing. So I'm trying to look at all my cases that I've done, and we're looking at 25 cases that are at least 1 year post-op, and I have matched them identical to gender, movements, because of the library of cases that I have, and I'm looking at 1 year afterwards to see the predictability of the planning, the relapse rate. The occlusal work's being done by Dr. Kong and Lucia Sevidantes at Michigan, and the scolial changes by one of my residents, and the results are going to be next year. And that's it. Thank you very much for your attention. Hopefully you learned up a couple of tips. I'm hoping that, I wish I was in San Antonio giving this presentation. I think by when this presentation takes place, the Raptors should still be the world champions, I hope. If you ever come to Toronto, come visit me at my office over there. Otherwise, thank you very much. My email's there if you have any questions. The references that are on this slide are just for clear orthodontics and everything. The handout should be, I don't have the PDF for that because this has been taped well ahead of that time, but hopefully we'll be able to manage that. Thank you all for your attention.